End-of-life care in general is a very painful process. And it's painful for a number of individuals, mostly the patient, but also the loved ones.
I think what's evolved over the last several years in terms of elderly patients with poor prognoses becoming what's called a DNR, do not resuscitate, I think that concept, which has been present for several decades, was a little bit taboo and I think not discussed by physicians, by nursing, by families.
I told my husband, if I am in a car crash or something happens and I'm going to be a vegetable, don't resuscitate me. I don't want to be resuscitated. Let me go.
I believe in having the patients make the decision. My role is to provide them with the knowledge to help them make that decision. Ultimately, the patients will have to decide if they opt for surgery that will prolong survival and sacrifice the quality of their life, or no treatment, or a treatment option that may shorten their life but give them the best quality of life in the remaining days.
I think what patients face and what their families face is quality versus quantity of life problem. Everyone wants to live as long as they can in the best way that they can. And no one wants to die. And everyone thinks that all they have to do is come into the hospital and get fixed. And no matter how good our technology is or how great our medical knowledge becomes, there are just some things that are not fixable. Broken kidneys and failing hearts and lungs that don't breathe anymore, no matter how many machines or medicines we throw at them.
Speaking from a Catholic tradition of 2,000 years, the world has changed so much, and the development of technology, which I've even seen just in my life, the world is in many ways different from the world into which I was born. We're asking questions now, or being asked to make decisions we never had to make before. 100 years ago, there wouldn't have been a question of do not resuscitate, or a question of what blood transfusions, or any of the technology we have, so that we have to be prepared always to understand newer realities.
What families can be often left with is this terrible position where their loved one has all this invasive measures, right? We essentially go barreling in and interrupt people's death. We interrupt what was going to be a natural death, and we intubate, and we bring them back, but they're not living, they're dying. So we are victims of our own success.
Typically, after cardiac arrest, the upper part of the brain does not work. It is more sensitive to the lack of oxygen and nutrients. Often, this part gets damaged and does not recover. And we are left with a person who has just the brain stem that is working. And those people will progress to what's referred to as a chronic vegetative state, in which they will be unconscious. However, they will have intact brainstem reflexes and brainstem functioning such that to the untrained eye, they may appear awake. These people will go from a coma in which their eyes are closed to having some restoration of sleep-wake cycles and periodically open their eyes with a blind stare. They may also have some reflexes where they may blink or they may cough and do things of that nature that to the untrained eye appears that the person is awake. That's the scenario that most families that I've spoken to are fearful of, that their loved one will be stuck in this state of unconsciousness totally dependent for feeding and for breathing and be bedbound without any awareness of their loved ones being around them.
When it comes to family and patient decision making, I don't think they realize the cost. I don't think they look at the cost. I don't think they know the cost. All they want is prolongation of life and keep the loved one around.
In terms of unnecessary treatment or futile treatment, I know actually of several cases. One that it comes to mind is a poor lady who started with a flu syndrome, was admitted to the hospital. The situation was complicated by multiple strokes, ended up being bedridden, and just having repeated admissions to the hospital. And the best she could do neurologically was to smile, unable to talk. The situation got ugly when the rest of her body started failing, including her kidneys, potential need for dialysis, congestive heart failure, and it was extremely clear to me that any further treatment would be futile. I shared the situation with my colleagues and nurses, and the conclusion was exactly that: futile treatment, 100%. Or, put other ways, any attempts to prolong life would be to prolong pain and suffering on somebody who was not capable of making decisions. Her relatives or loved ones, in relatively large numbers, insisted on prolonging the agony, and the situation got ugly to the point in which security needed to be called into the room because the relatives were fighting with each other about yes and no and how to proceed, and it was quite painful. The patient remained unaware of the circumstances because of her neurologic damage. The situation went on for a while, just to finally, when she was basically dying actively, somehow reason sank in and she was made care and comfort, which means stop all futile interventions, and she was let go in peace.
That person can't speak for themselves, so as a palliative nurse at that time, and certainly after as a hospice nurse, I'd be asked to talk to and try to clarify goals of care with the people that were left behind, whether they're healthcare proxy or a wife, and try to encourage them to understand that if their loved one could sit up in the bed and could have a conversation and tell them, what do you think that they would say? Would they ask you to continue to do these things, or would they ask you to allow themselves to pass away? And maybe think about that.
Reflexes that you see from the lower part of the brain, or the brain stem, are the ones that are often most confused by family as to feeling that the patient is awake. One can be brain dead, but still have a spinal cord reflex. An example of a spinal cord reflex, you tap your knee and your leg jumps. That's a message that goes from the knee to the spinal cord and back down again, does not require any brain function. Examples of these types of reflexes would be you call the person's name and their eyes open up, or you touch the cornea and the eyes blink, or you stimulate one of the limbs and there's certain types of posturing. These types of reflexes get up to the lower part of the brain, turn around and come back down, but they don't make it to the cerebral cortex.
What's really important is a neurologic recovery. That's what's typically discussed and stressed with family. Will the patient have a stroke with permanent neurologic damage?
Now, if a patient is elderly and mechanically ventilated without any communication with the environment, it's inhumane to continue treating this patient this way.
I don't find it difficult for people to make what I would consider to be intelligent, informed decisions about their own code status when I frame it to them in the way that I believe it should be framed, which is a protection against a tragic or painful death without limiting any potential treatment options they may have for their underlying illness.
After a cardiac arrest, nobody knows the exact time that your brain can be deprived of blood flow and oxygen. It's certainly not long, whether it's 10 minutes, 15 minutes, 20 minutes, 30 minutes, it's somewhere in that ballpark. And once your brain cells die of lack of oxygen, generally there's no way to reverse that. And that's generally how people who survive the initial cardiac arrest don't survive long enough to leave the hospital.
Even surviving such a drastic tragedy and horrible event such as sudden cardiac arrest might not increase life expectancy more than 60 days at best. And what they're facing is seeing their loved one dying on a hospital bed by themselves, surrounded by unfamiliar people, hearing unfamiliar voices, confused, medicated, not home.
Death is a reality of life, and I think the more dignified, proactive, and comfortable way you can deal with that, the better.
At the end of the day, about 90% of the people who drop dead actually stay dead.
Less than 5% survived to full neurologic recovery.
I treated a lot of physicians in my practice, and interestingly, most doctors who understand the circumstances also express their wish to be DNR, knowing the very limited value of these heroic measures, especially for advanced disease. Again, good education, open, neutral discussion are helpful, but personally, if the time comes, I would like to die peacefully with dignity.
Compared to other physicians, I tend to be more aggressive in treating the patient to prolong life or give them a chance. But if somebody's up there and there's no chance of survival, I don't push for continuation of mechanical intubation.
Dying from the normal disease process might actually be a much more humane way to die than going through a code and compressions and breaking ribs and breaking the sternum and then having a stroke. And it can also be much more difficult on the family if they end up on a ventilator. And now the family has to decide when to take them off life support, and that's a horrible decision for anybody.
In simple numbers, if 100 patients drop dead because their heart stops for whatever reason, only about 2, perhaps 5 of those will ever be themselves again. About 5 of those will have neurologic damage, and the other 90 will never truly come back to life.
As to whether patients understand the term cardiac arrest or code, in some cases you really have to make it in simple terms and say, what I mean by that is your heart stops and you die, or something to that effect.
I think the general population misunderstands what do not resuscitate means. Do not resuscitate does not mean do not treat.
So I distinguish resuscitation status completely as a parallel track from dealing with their illness and all of the medical technology we can bring to bear to accomplish that. And once it's viewed as not part of their medical treatment, but they understand the realistic expectations of a resuscitation event in someone who has a terminal illness and the ramifications that may have for how they lead the rest of their life were they to be successfully resuscitated, I find that the patients have a much easier acceptance of deciding not to be resuscitated when they truly learn that it has no bearing on my interest in their care.
The end-of-life discussion is not compromising care. Unfortunately, sometimes there is a connection. This question sometimes could be perceived as, a wish to compromise the treatment or not providing the treatment. And I think as physicians, we have to make that distinction. I think we should move forward with the best treatment available. However, patients should be given the right to express his or her wish when it comes to end of life.
So one of the things that we do with patients to prevent really the potential for litigation is that we prepare what's called the healthcare proxy for them, which basically allows them to appoint someone to make a medical decision for them should they reach a point where they're not able to effectively communicate that decision to their doctors. And through that discussion with our patients, we also get into a statement of desires with them, where we put into the healthcare proxy their predetermined desires to, in essence, plan ahead for end-of-life situations.
At some point, all of us are going to die, and coming to grips with that and dealing with it and preparing for it is really very important.
I think this is a kind of discussion every patient, including myself, should hear. This opportunity must be given, and I think this should be part of the medical field's role, bringing the awareness to the discussion of end of life.
Sometimes patients are asking, and I recommend that this is very survivable and you should be a full code.
So there's no clear-cut cookbook type of treatment and decision-making when it comes to DNR.
The key concept is it's fluid. What you decide today when you're making those decisions may change tomorrow, next week, next year, at any point. So I think from that perspective, it really is important that people understand what the concept of do not resuscitate means. It doesn't mean give up and don't try to make anything better. It means in the event of a catastrophic cardiac or pulmonary or respiratory arrest, that you wouldn't want to go through a resuscitation protocol with a low probability of success.
All it really matters, and what I've kind of come to understand, is that you have picked one person to speak for you, because at some moment you're not going to be able to speak for yourself.
So we try to protect them with this document and also use this document to educate their loved ones who they may not have had this discussion with if that situation arises, so that, a son or a daughter can say, hey, here's what mom and dad wanted. It's right here in this document. It's right here in their healthcare proxy. This is what they would want at this situation.
There is no more vulnerable time in your life than when you're dying. And to be able to give that, to do everything and however it is, not what I want, but what you want.
Many of the patients that I see in the hospital do have advanced disease, and some of them could be defined as being in the terminal phase of their illness. Defining the terminal phase can be very complicated, although it seems pretty straightforward to many people. In some cases, it is straightforward, where a person is actively dying and it's evident to the doctor, the patient's family, and the nursing staff who are involved in the care. In other cases, it's not so clear. The patient can have an illness for which we have no treatment, for which their life expectancy may be limited, but whether it's limited to weeks or months can be very difficult to know, primarily because medical complications that can be terminal can happen unexpectedly.
I think that we always have to develop, as individuals, as a church, an understanding of newer realities that directly affect life as we live it and as it draws to a close. All the technology, all the capabilities we have must always be viewed in terms of the dignity of the human person, our ethical and moral principles, our faith, and our understanding of the meaning of life itself.
It's always a challenge if a patient turns and wants to know what your opinion of what they should do is, because we all have different life values and I probably don't really know what their whole situation is in their life. However, if they're asking me, I think it's my job to try and give them as informed an opinion as I can, while I'll probably make a statement to the effect of, I don't know everything about you, and certainly there are miracles that happen that we can't explain, so I might be telling you I don't think this is survivable. That's only a best educated estimate.
It's really kind of strange, but nobody gets out alive. You know what I mean? And you get to a point to where you say to yourself, well, Jesus, am I there? Is the door really opening for me or whatever? And it is for me, you know. And it's hard. It's very hard sometimes to sit there and think about this and everything that everybody else is doing for me. Stuff that at some point I'm not going to be able to thank them for, you know? This is something I did not want to do. But you need to know that during these treatments or the work that you put into bringing up a family was worth it all. And I think it was, just by the way my children react in this thing. I mean, they know. And again, I'm sure that it's going to be a little bit different as time goes on, but I think they know that I'm doing the right thing.
My name is Jerry Gaudreau. I have cancer. 4 weeks ago, when they were testing me for knee surgery and found out that my blood wouldn't take the operation, and then they sent me to the hospital to take another blood test, and when I took the blood test is when they found out that I have leukemia.
I have a condition. I am a type 2 diabetes. I have retinal disease, stage 5, and I have diabetic neuropathy and double vision, and that's it.
I'm going to be pretty sick because I think, I guess because deep down in my head, I'm not ready to go yet. Now, and that has a lot to do with how I feel right now. You know what I mean? Because I feel pretty good. I mean, I got to be honest with you. I'm sitting there, I sometimes have difficulty facing this fact that I'm sick. I've had a few weeks where I feel honestly like maybe I'm making a comeback, but I know that that's not the case. And I only know that because I trust the doctors who are working with me on this. But I know that right now, right this minute, the way things are with the treatment that's available to me, at best, I believe that it's being held at bay.
Families usually react to the patient's illness, even when the situation is critical, tends to be highly emotional. We do discuss the statistics. They might listen to that or not, but the expression he or she is a fighter surfaces quite frequently, and that argument is used to believe that it can overcome the overwhelming worldwide statistics.
Statistics from our group is that majority of our patients surviving to discharge after cardiac arrest will pass within 60 to 90 days.
A vast majority of people with cardiac arrest, even those that seemed to be quickly resuscitated, had significant brain damage to the point where they often were left in a chronic vegetative state.
Look at all of the data on cardiac arrest. The probability of leaving the hospital is very, very low, probably in the 6 to 10% range.
Coming out of the intensive care unit is a miracle every time.
There are many patients and families who acknowledge that their illnesses are going to shorten their lives. What I see in patients and families is the transition from shortening their lives to understanding that they are terminal, that there is a finite, that there is an end coming. Shortening my life is different than saying I am going to die. So one is nebulous, one has an upcoming point in time that's soon. Even though neither one has an end date, we never know the end date, one is less concrete than the other. And I think the terminal part is where families and patients have a difficulty.
In my experience, I think people avoid the idea of it. Not all, but many avoid the idea of their own mortality and oftentimes the mortality of someone whom they love. And you see it after a death where people will be very resentful about the fact that someone has died, or go into a grief and a mourning that's extended or resentful. I think there's almost a disavowal of it generally.
My wife, who is a retired critical care nurse, taught me the line, "Death is not a failure." And I think it's a very profound statement that all of us are going to die at some point. It's unavoidable. It's an inevitable fact of life. And I think all of us in medicine feel that if somebody dies, it's a failure for us. And I think it's difficult for providers to overcome that feeling. And I think it's been a slow process, but I think the evolution of accepting death with dignity and compassion and comfort is evolving into a very good thing.
We as physicians are trained to treat in medical training and not to give up and let patients go. So it starts from us.
But nobody failed because everybody dies.
Cases that I remember about running a code, the first was in the Kwai River Christian Hospital in Thailand. It was a baby that was brought in who had just arrested on the way into the hospital. And we ran the code with the minimal equipment that was available. And unfortunately, the baby did not survive. What was most memorable to me, I was a resident that was going to graduate in a couple of months. And in all the codes that I had run over my residency, the family there in Thailand was overwhelmed that anybody would actually have made as much effort as we did to try and save the baby. So that's one very sad but memorable code. And the other situation that I remember as being a very difficult code was a teenage boy who had been playing baseball with his friends. A friend batted the ball and it struck him in his chest, and he had a cardiac arrest. And he was also one that we did not save, but it was that's the codes that you don't save, and in my case at least, more so than the codes that you do save.
Frequently, I will say in a sermon at a funeral mass, grief is the price we pay for love. But we're happy to pay it, because the only way not to have the grief is not to have had the love. And you wouldn't give up the love your mother showed you, your father showed you, your husband or your wife. Everything comes at a cost in life. And that when we begin to understand that, it softens the hardness of life or the suffering or what you've seen someone you love endure.
They have determined that I have stage 4 metastatic esophageal cancer. The outlook is not good. What I'm doing right now is basically trying to hold this thing at bay because there are new things happening every day, and I know I'm not under the impression that anything as good is going to happen to me. I'm not that optimistic or anything like that, but I do know that in the meantime, if I don't do something, I think, because I feel, strangely enough, I feel good. I don't feel as bad as I have been, or as I had back when they first diagnosed me, when they first started with the protocol, with the chemo. But right now, that's where it stands with my health, with my care. I'm about ready to start up. I had this conversation with Dr. Oddman again, and I've also involved my family in all the discussions and questions about treatment and everything. Everything I tell you guys and yourself, Doc, and the people at the oncology, I tell my sons and my daughter every chance I get. When I have a meeting with a doctor, I have a long-term conversation with them, and I kind of spell it out where I'm going with the thing.
For all of us, chronically ill patients and even healthy people, the end of the road is dying. Death is inevitable for all of us.
I struggle with the pain it puts my family through if I continue with this, because I don't want to put them through any more pain than they have to be, you know.
If I can't breathe or do anything physically myself, I don't want to be on life support or feeding tubes or anything like that, because I saw my father went through hell being on the machine.
I have my own personal bias that under virtually no circumstances would I ever want to be resuscitated, because the statistics for meaningful recovery are rather dismal if one requires a resuscitation event.
I understand the DNR thing completely, but I don't want anybody else to have to make that. That's all going to be my decision. My children don't have to deal with it. They're going to have enough to deal with, you know, at some point down the road. So, you okay with that? You know what I'm saying? It's very important to me. It's very important to me that people understand that when I decide it's time to go, I'm making the call. I'm going to pull the pin then. That's, you know, and when it gets to a point where I have to sit there and say to myself, that's it. I'm done. I don't want them to have to sit there and don't even think about asking them. You know what I mean? Because it's not on them, it's on me.
Making an advanced plan or choosing a healthcare proxy is something that is almost a gift to your family. It's something that takes away the anxiety and the burden for your family in the time when you're dying or you have died, that you've already chosen your wishes. Or if you can't speak for yourself, they have something to follow. They know what you wanted and they can do what you asked for. You can take the time to tell them what you're thinking now before things happen. You don't have to be terminally ill to do this. You don't have to have a chronic illness to do this. You can do it now when you're young and healthy. And you can change it 10 years later if you so choose. But think about it now and put it in writing now. Think about whether or not you want a feeding tube. Think about whether or not you want to have pain medication. Think about whether or not you want to have a catheter. Talk to your doctor, talk to your nurses, think about those things and put them in writing. So if the time comes, when the time comes, your family knows what you wanted and can act on it.
What would you want to have happen if this situation arises, a terminal illness, and the treatment you're receiving is only artificially prolonging the inevitable? At what point do you want to stop maybe receiving that treatment?
When my time comes, which I suppose it means I'm at the end of significant illness and the end seems inevitable, I will be unquestionably DNR. What I encounter in my own practice is that patients ask, can you give me at least one shot? And I think that if that happened today, given the fact that I'm completely healthy, I would go for a shot, meaning full code. However, I would clearly specify that whenever the moment comes in which hope is lost, I would not hesitate to stop my own treatment and become complete DNI, and even withdraw care at that point as a way to stop the pain and suffering that I so often see?
I think it depends upon individual cases. Certainly what one would do in the case of someone who was 14 years old or 20 years old might very well be different from what you would do in the case of someone who was 84, 85, or 90 years old. You're always bringing your general principles to individual cases and trying to be intelligent and artful in the decisions that you make. The idea of a full code always and everywhere when the person has come to the end of their life is, I think, inappropriate. People have a right to die, and to die with dignity and grace, in my view.
When my time comes, I would choose to be a DNR. I know that medicine is amazing and technology is amazing, but I don't want to be kept alive just for a duration of how long they can keep me alive. I'd rather spend my last days, weeks, months, and at least be comfortable, rather than the emphasis being on length of life.
Do not resuscitate, and I repeat, does not mean do not treat. So if I were to develop some sort of illness, say that I came up with breast cancer or some other cancer, and I decided that I was going to go through chemo and radiation, I might choose then, even as young as I am now, to become a DNR.
I've already made that decision about full code and DNR, and the decision is DNR. I think we follow always best medical advice, but it's something that my brother and sisters and I, my family, we've all discussed, having faced, my father's death, my mother's death, and the death of my sister's daughter at the age of 2.5, that we discussed as a family what life means. And it was interesting, when my father was first taken ill with a stroke, he called, the doctor said, he wants to see you. And I came in, and he looked at me and he said, if this goes sour, no extraordinary means. We're not putting your mother through this. And the second thing, mother gets everything.
So my wish for the people that I love would be that they tell me what they want, that they're thoroughly honest with me and let me know how I can help them when it's their time. Not wait. Don't leave me guessing, and let them know that they can change their mind at any time. Don't do what I want just for me because they think that's what I want them to do, because people do that all the time. I want to know what it is that they want for themselves, and that's all.